Good morning. The next portion we are going to cover is your finance. That means in dentistry or in general in medicine, how you are going to deal with your treatment cost and what are the modes of payments prevalent in our country and in some other countries. So that's what we are going to deal with today. So about dental payments. Healthcare systems of India. Before coming to the payment systems, we'll just go through the healthcare systems of India and in what all ways are the health is going to uh, provided by the government to the public. So the first one is public health sector. It's a primary healthcare, then hospitals and health centers, and your health insurance schemes and other agencies. So in public health sector, this is providing basically by the government of India. So it's basically through primary healthcare, that is primary health centers, sub centers. Then coming to a little bigger concept of community health centers, rural hospitals, district hospitals, specialist hospitals, and teaching hospitals. Then comes the health insurance scheme, which is run by government, or ESI, that is employee state insurance. Then central government health schemes and other agencies like defensive services and railway services. In this defensive service and railway service, already there will be a medical team along with them. In railways, there are railway hospitals. So those who are working under that particular area, they are getting treatment from that particular services. So as we all know, then the second one is private sector, that is private hospital, polyclinic, nursing homes and dispensaries, and general practitioners and clinic. And most of the populations are making use of this private sector, maybe more than 50% of the population. Then indigenous systems of medicine like Ayurveda, Siddha, Unani and Tibbi, homeopathy, unregistered practitioners. That is also there are some quacks practicing or unregistered practitioners. Unregistered practitioners are considered as quacks. So they're also treated by some of them. Then Ayurveda and Siddha, that is all registered things. Then we have some voluntary health agencies, which they will conduct as a camp or any other social responsibility procedures. Then comes the national health program. Some national health programs are running by the government of India. So under that, the patients are getting treated like vaccinations and DOTS kind of treatment for tuberculosis. Then coming to the mechanism of payment of dental care. So that is private fee for service, then post-payment plans, a private third-party prepayment plans, salary and public programs. These are the main components or main way of payments in dental or medical services. All these payments are not uniformly there in any of the countries. So there can be a difference in payment methods here, and some places there will be a combination of these payments. So first we'll see each of the one. Private fee for service. It's a two-party arrangement. The first party is patient and the second party is your dentist. That is the traditional form of reimbursement. In 1970, nearly 90% of the payments was in this manner. But by 1988, dropped to 55% of all payment because growth in the various form of prepayment methods like insurance. The advantages are it's simple and culturally acceptable. There is a flexibility for dentist. The dentist can practice a price discriminations, also called as Robin Hood approach. In the sense, this price discrimination can be given to poor patients, like less amount can be given to the poor patient, and accordingly can increase a slight amount from the rich people. So it's just basically a kind of Robin Hood phenomena. So only system under which some expensive form of treatment will be provided. and such kind of treatment is prevalent in India. Then comes to post payment plans, that are budget payment plans. There's no true third party financing plans, and dentists allow payments for dental care to be made at intervals over a period of time. Under budget payment plan, the patient borrows money from the bank or financing company to pay the dentist at the time he received the care. The patient then repays the loan to the bank. This is a system in which for treatment, the patient is going to take a loan kind of thing from the bank, and then he's paying back the amount to the bank in return in increments. So disadvantage of this post payment is mostly used by middle class people, as low income patients were not considered as credit worthy by the lending institution. This is one of the main disadvantages. Those who are socially backward or economically backward people, they won't get a proper treatment, and they won't get a proper loan because they won't be having any lending institutions to borrow money from. Then comes to the biggest area of this private third-party prepayment plans. It's defined as a payment for service by some agency rather than directly by the beneficiary of those services. As a party to a dental prepayment contract that may collect premiums, assume financial risk, pay the claims, and provide administrative services. The dentist will be the first party, the patient will be the second party, and the administrator of the finance will be the third party. They're also called as carriers, insurer, underwriter, or administrative agents. These are the different names given to them. And the purchaser of the plan can be an organized private group such as a union or an employer, a union employer welfare fund, or a government agency. The term third party refers to a private carrier such as an insurance company, public financing of care when the government acts as the third party. In private third-party plans, periodic premiums are collected to meet the cost of providing care as well as the administrative cost of the third party. Most of the prepayment plans, dental insurance are not much included. So coming to the insurance, involves a group of people making small payments in order to cover the risk of a few suffering catastrophic loss, such as the loss of home through fire. And dental prepayment is a mechanism to spread the financial load of dental care over a group and over time. To be insurable, a risk must be precisely definable, be of sufficient magnitude that if it occurs, it constitutes a major loss. It should be infrequent, be of unwanted nature, such as destruction of home through fire, be beyond the control of the individual, should not constitute a moral hazard, which means that the presence of insurance itself should not lead to an additional claim. All health insurance violates some of these principles. For example, benefit paid a small amount of money, and people with insurance are more likely to use care than those who do not have it. So those who are having an insurance, they are frequently going to health checkups. So they're more get benefited with that. To get around these problems, insurance carriers come up with some of the techniques, that is deductible, co-insurance, range of healthcare services, health insurance only to group, using pre-authorization and annual expenditure limits. So we'll see each of them. So deductible is a set amount of money that patients must pay toward the cost of treatment before benefit of the program go into effect. This is to counteract that when some patients are having, or some person is having a disease and he came to know that, he can immediately go to a insurance company and he can take the insurance or purchase the insurance. So to avoid that, they are giving a time period, time lag from which the payment is given, and the insurance is applied to that particular patient. So that is called as a front-end payment. The other name of this deductible is front-end payment. Usually it may take up to 1 year. Co-insurance. The next one is co-insurance. This means the patient pays a percentage of the total cost of treatment. Example, if a patient is to pay 20% of the daily cost of the hospital care, the amount the patient must pay will vary depending on the actual hospital charges, but in any case it will be 20% of those charges. So one percentage of charge should be taken by the patient, and the next 80% will be taken by the insurance company. So the patient won't be going for such a big treatment or a such expensive room or executive rooms, because patient also has to pay a percentage. So it can limit him from overusing the insurance. And range of health services, some are available and some are not. There will be limitation of healthcare services. So that also can increase the profit of these insurance companies. And the other thing is pre-authorization. That means the treatment plans for more than a specified sum must be reviewed by the carrier's dental consultants. These insurance companies have some dental consultants. So if we are going for a high cost treatment or any other big procedures, that insurance company, there will be a representative, a dentist. He must pre-authorize and approve it. Then only the insurance company will provide the claim. And health insurance only to group, because illness experience is reasonably predictable for a group, though not for an individual. And the risk of adverse selection was reduced because insuring only large groups averaged out the risk. The probability of adverse selection was further reduced by the use of waiting period after enrollment before any benefit become available. So these are the techniques which are used by an insurance company or insurer or third party to prevent the overuse of the insurance or the claims. And how we are going to reimburse the dentist in third-party payment plans in various areas of the globe. And the major form of third-party reimbursement currently in use are usual, customary, and a reasonable fee, that is UCR. This is going to be asked as your short notes. Then comes the table of allowances, then fee schedules and capitation. The ADA defines usual fee as the fee that an individual dentist most frequently charges for a given dental service. The fee that an individual dentist most frequently charges, because it's going to be a usual fee. Suppose for a scaling and polishing, they are charging a certain amount that will be frequently charged by a dentist or a group of dentists nearby. So the customary fee is the fee level determined by the administrator of a dental benefit plan from actual submitted fees for a specific dental procedure to establish the maximum benefit payable under a given plan for that specific procedure. Reasonable fee, the fee charged by a dentist for a specific dental procedure that has been modified by the nature and severity of the condition being treated, and by medical or dental complications or unusual circumstances, and therefore may differ from the dentist's usual fee or the benefit administrator or customary fee. And table of allowance is defined as a list of covered services with an assigned dollar amount that represents the total obligation of the plan with respect to payment for such services, but that does not necessarily represent the dentist's full fee for that service. For example, if a dentist's usual fee is $20, the plan list for the service it will be $15, and the dentist will provide the service, collect $15 from the carrier or the insurer, and may charge the patient the next remaining $5 to make up the difference. And fee schedule is also called a service plan. Is defined as a list of charges established or agreed to by a dentist for specific dental services. A program in which the payment is meant to represent full payment with no additional charges to the patient. Dentistry's opposition to fee schedule is based on their potential inflexibility, meaning that the fees listed can fall below customary fee, particularly in types of rapid inflation. The implicit assumption that all dentist treatment is of the same quality and therefore worth the fees, and the fear that autonomy is threatened, especially if the fee schedule is not controlled by the dentist. These are the common reasons which the dentist can oppose for the fee deciding by the third party. Then comes the capitation, become more common during the 1980s. Is defined as a fixed monthly or yearly payment paid by the carrier to the dentist in a closed panel based on the number of patients assigned to the dentist for the treatment. Again, it will put the dentist on the back foot, because there can be a chance of high utilization of the uh, insurer and the patient, and demand of expensive treatment can come, which won't come in this yearly or monthly payment, or which exceeds that particular amount. Then comes to the Delta Dental Plan. A dental service corporation is a legally constituted not-for-profit organization that negotiates and administers contract for dental care, incorporated on a state-by-state basis. National Association of Dental Service Plan (NADSP) was formed in June 1966 with the help of ADA. NADSP changed its name to Delta Dental Plan Association in April 1969, and the member corporation became known as Delta Plan for the particular state. So Delta Plan and dental services are synonymous, and most Blue Cross and Blue Shield dental plans are now also organized as dental service corporations. So basically, they are non-profit organization. They will negotiate for the amount for the dentist, and they will only arrange the patients, and they will act as a proper third party in between. That is exclusively run by the UCR concept. Reimbursing depends on whether the dentist is participating or non-participating in the Delta Plan. Participating dentist, any duly licensed dentist with whom a Delta Plan has a contractual agreement to render care to covered subscribers. The payment mode will be changed according to this participating or non-participating. By participating in Delta Dental Plan, the dentists agree the following: that is, pre-filling of their usual and customary fees, acceptance of payment for their services at the 90th percentile, fee audits by auditors from Delta, which may check their office records from time to time, and post-treatment inspection of randomly chosen patients, and withholding of a small amount of each fee, usually less than 5%, to go into a Delta Capital Reserve Fund. And non-participating dentists can also treat the patients covered under Delta plans, but they are reimbursed at a considerably lower percentile, median or 50th percentile. So this is a diagrammatic representation of the 90th percentile. The maximum cumulative frequency distribution of dentists is in the y-axis, and the sum is given in the x-axis. And here the mean fee is $12.78, and coming to the 50th percentile, it will be 12.50, and 90th percentile will be $14. That means most of the patients who are paying less than 90 will be considered there. Health Maintenance Organization was defined in the Act 1973 as a legal entity which provides a prescribed range of health services to each individual who has enrolled in the organization in return for a prepaid, fixed and uniform payment. Independent Practice Association is an association of dentists that develops its own management and official structure for the treatment of patients enrolled in an HMO. Dentists remain in their own office and continue to treat their fee-for-service and other patients. The Independent Practice Association receives its capitation premium from the HMO and in turn reimburses the individual dentist on either a modified fee-for-service or capitation basis. Preferred Provider Organization, PPOs typically involve contracts between insurers and a number of practitioners who agree to provide specific service for fees that are lower than average in that particular area. Then comes to direct reimbursement, involves an agreement between employer and a group of employees in which the employer agrees to reimburse the employees for some part of their expenses of dental care. The patient is responsible for paying the dentist from whom they get the service. All treatment decisions are thus negotiated between the patient and the dentist in a traditional two-party manner. After treatment has been provided and the patient takes the receipt to her employer and is reimbursed for her expenses according to the rules of the agreement. Reimbursement is usually on a percentage basis and there is usually an annual limit for that. Then come to the Medicare, which is prevalent in United States. The title 18 of the Social Security Amendments of 1965 is a program known as Medicare. Medicare had two parts: Part A, hospital insurance, and Part B, voluntary supplemental medical insurance. The dental segment of Medicare is limited to those services requiring hospitalization for their treatment, usually surgical treatment for fractures and cancer. Title 19 of the Social Security Amendment is a joint federal state program with the federal government and state government sharing the cost. They have particular percentages for that, how to calculate for that percentage from each federal and state government. The federal government provides 50 to 83% of the funds used by each state according to a formula that is based on the ratio of per capita income in the state to the national per capita income. In order to qualify for the federal government share of Medicaid financing, every state covers a set of basic services for everyone receiving federally supported financial assistance. State offer early and periodic screening, diagnosis, and treatment to needy children at least up to age of 18. Dental care is mandatory under the EPSDT program. So these are the prevalent third parties mechanisms in action in India. The government itself acts as a third party here, that is employee state insurance scheme and central government health schemes, life insurance corporation, that is LIC, and general insurance corporation, that is National Insurance Corporation, NIC, New India Assurance, Oriental Insurance Company, United Indian Insurance Corporation, which provide claims for that particular patients or a group of patients who are enrolled. Then comes Central Health Government Scheme, CGHS, introduced in 1954 in New Delhi to provide comprehensive medical care to central government employees and their families. 320 separate dispensaries for the employees covered by this scheme. It covers the beneficiaries are the central government employees, retired central government employees, widows receiving pensions, members of parliament, ex-governors, and retired judges. Facilities under this particular scheme is outpatient care through network of dispensaries, supply of necessary drugs, laboratory and X-ray investigation, then domiciliary visits, hospitalization facilities at government and private hospitals. Then specialist consultation, a pediatric consultation including immunization, antenatal, natal and postnatal care, emergency treatment, supply of optical and dental aids at reasonable rates, family welfare services. There are a number of treatments provided in this particular scheme. It's very useful for that particular group of patients and family. Then comes Employee State Insurance Scheme, ESIS, established in 1948. ESIS is an insurance system which provides both cash and medical benefits. Managed by Employee State Insurance Corporation, a wholly government-owned enterprises. The scheme covers non-power using factories employing 20 or more members, power using factories employing 10 or more persons, road transport establishments, newspaper establishment, cinema theater, hotels, and shops. Only employees earning basic salaries of less than 3,000 rupees are eligible. Recently, it has been enhanced to 6,500. Premiums are paid through payroll tax of 4.75% by employer and 1.75% by employee. Mediclaim policy of the GIC, that is General Insurance Corporation. It was set by government in 1973 as a public sector organization to market a range of insurance services. It introduced Mediclaim insurance scheme in 1986 and became active in 1987. Policy was modified in 1996 to allow for differentials in premium for 6 age groups. Policy was framed for both groups and individuals. Mediclaim provides only reimbursement insurance, that is, enrollees are reimbursed for their medical claim only after the payments have been made out of the pocket of the provider. Some insured ranging from 15 to 5 lakhs. The salient features are it provides or covers which takes care of medical expenses following hospitalization from sudden illness or accident. Cover extends to pre-hospitalization and post-hospitalization for periods of 30 days and 60 days respectively. Then domiciliary hospitalization is also covered. Major weakness of Mediclaim is it covers only hospitalization, leaving out outpatient care. The coverage is subjected various exclusion limits and restrictions on eligibilities. Premiums are high in relation to claim payments. Claim payments are only 58% of the premiums. So these are the major areas or financial schemes prevalent all over the globe, and particularly in India. So we have seen, and most of the dental insurances are still on a pipeline. So some of the companies like Hindustan Unilever, they are giving dental insurance also, but again there are so many restrictions from the insurer side or third party side, because the dental treatments are all expensive and there comes a lot of lab works. So it's always a difficult area for this third party to calculate the reimbursement and all their claim policies. So, but still slowly it is in a growing stage. So if you are having a federal system of payment, so it can benefit a lot of people. So that's it. And other things, the basically now the payment plans are going on a private fee for service. Almost more than 80% of the dental payments are going through only through this payment fee for services. So this is one of the major chapter, important chapter. So you can get minimum 3-4 short notes and then complete essay as finance in dentistry. So I suggest to go through this. It's a little confusing topic, but you have to have some multiple readings through that. So that's it. Thank you.